This is Renal GU's Disorders, Part 2. The focus is going to be on hemolytic uremic syndrome, which is one of the causes of acute renal failure in children. We abbreviate hemolytic uremic syndrome as HUS. It's caused by toxins of some sort, and frequently you'll hear on the news about the toxigenic E. coli, which leads to a bloody diarrhea. This toxin not only affects the endothelial lining of the intestine, it also causes damage to the endothelial lining of the blood vessels, and particularly the capillaries, leading to occlusion due to an inflammatory response. The effect on the capillaries is systemic, and it affects perfusion. The inflammatory response affects the capillaries systemically, therefore reducing perfusion. And this is particularly severe when it affects the glomerulus of the kidneys. In addition, occlusion of the capillaries causes a hemolytic anemia as well as thrombocytopenia. Since hemolytic uremic syndrome affects the intrarenal system, this child will have symptoms of fluid overload versus a prerenal cause of acute renal failure. That child would have signs of dehydration. If the fluid overload is severe enough and can't be corrected with medications, the child may need dialysis. The urine output for this child who has HUS is between normal to decreased. It is not complete oliguria. So once again, when we do an assessment of HUS, there's bloody diarrhea. We will send off stool cultures, and the results will come back as the toxigenic E. coli. When you look at the urine and when you dip it, you will find hematuria, proteinuria, and when you look at a urinalysis, you will see the presence of casts. When casts are present in a urinalysis, that is indicative of glomerular damage. Some of the kids who come in with HUS can actually develop shock. When you do your physical assessment, you're looking for fluid retention. You'll be monitoring the chemistries. In particular, focus on the electrolytes, acid-base balance because of metabolic acidosis. You'll look at the CBC, and you're not going to see changes in the white cells necessarily, but you definitely will see a decrease in the hemoglobin hematocrit as well as the platelet count. The child may be hypertensive. It depends on the degree of fluid overload. Also, depending on the electrolyte level and that potassium, the child can have arrhythmias, and for this reason you will place the child on a cardiac monitor. Monitor your patient for deterioration of the central nervous system. There are a variety of diagnostic tests that are going to be ordered for this child. If the cause of acute renal failure and the hemolytic uremic syndrome is not 100% evident, they're going to start looking elsewhere, meaning they might be doing an IVP. But keep in mind, we cannot do an IVP unless we know what the child's creatinine level is, and so it's your job to let radiology know. When we may do radionucleotide studies, and they might even do a renal arteriogram. If they do an ultrasound, they're still unsure of the cause of what's going on, so they're looking at the size of the kidneys. Is there hydronephrosis present? Is there some type of an obstruction? Are there tumors, or do they have something like polycystic kidney disease? The laboratory values are going to be very important. When you're looking at the chemistry panels, pay attention to the creatinine and the BUN. Look at the sodium. It can be either increased or decreased. Calcium can be decreased. In the case of renal failure, of course, the serum potassium is going to be elevated, and this is what causes the arrhythmias. Phosphorus will be elevated, and it might be elevated to the point that we have to give phosphate binders. If the patient has hyperkalemia, the first step to improve it is to administer Kxolite. Now, if the child does not respond to the medical therapeutic interventions, then they move on to dialysis. Because the kidneys can no longer excrete the hydrogen ions, the child develops metabolic acidosis. So the pH is going to be decreased as well as the bicarb. So clinical problems that are associated with hemolytic uremic syndrome and acute renal failure include the fluid overload. They're going to have third spacing, therefore edema. They will have pulmonary edema. They may even have ascites. In the respiratory tract, you would anticipate this child to be tachypnic. As stated above, pulmonary edema, and they may have respiratory failure, so be prepared to assist with intubation if needed. I want you to critically think about what signs and symptoms would the child exhibit prior to developing respiratory failure. You need to be able to recognize these signs. Also, what will pulmonary edema look like on your patient? Monitor the vital signs, the pulse for regularity. Look at their neurologic system. Do they have a decreasing level of consciousness? Are they having seizure activity? They may even develop an intracranial bleed because of the hemolysis. The child is at risk for other infections, and with the edema, they can have skin breakdown. And then because they are not eating nor are they filtering correctly, they can have malnutrition. So your nursing interventions primarily are going to focus on maintaining fluid and electrolyte balance. So once again, Kxolate for hyperkalemia. You may be administering bicarbonate for metabolic acidosis, and you may be preparing the child for dialysis. Keep the child on the cardiac monitor, monitor their respiratory status, once again, being prepared for emergency intubation. Of course, we'll sedate the child in this case also. Complete a neurologic assessment, monitor their blood counts, watch for bleeding. Minimize where we are poking and prodding this child because they may continue to ooze out of the sites that we are accessing. Assess the child and protect them from infection. Many of these children end up in isolation simply to protect them. Promote nutrition, and so if the child doesn't turn around quickly, then you would anticipate that intravenous nutrition in the form of TPN and lipids would be administered. Assess your child for pain and promote comfort. When they have edematous extremities, it's very painful. You want to turn this child at least every 2 hours and elevate the extremities with pillows. It's very important to help the families cope with this illness. It's something that comes on very quickly, and they've gone from a normally healthy child to a child that may be intubated, sedated, on dialysis, have 8 or 9 lines, and numerous medications. Always explain to them what it is that you're doing and have them assist you with the care of their child whenever feasible. This ends part 2 of renal and GU disorders.